I'm very ready. Let's do this.
Okay, welcome everybody. Hope you all had a good spring break, and glad you could make it back for this talk, which is not at our usual time. We usually have this conference on Thursdays, but when we have special guests, we change the date, and we do have a special guest today, Dr. Mohammed Saeed Malas from Indiana University, who I guess he said it was okay since this is being webcast. I can mention to the world that he's here interviewing for a faculty position in DMICE and also with the Division of Nephrology in the Department of Medicine. Dr. Malas is originally from Damascus, Syria, where he obtained his medical degree at Damascus University. He then came to the United States and did a residency in internal medicine at Indiana University. He completed that. He's board certified in internal medicine and then entered a fellowship in nephrology and is on the verge of completing that. And also at the same time has been in a clinical informatics fellowship at Indiana as well. So he's meeting with folks from both informatics and nephrology in the Department of Medicine. His talk today, I don't have the title here. I'll let him put up the slides so you can come on up and
Go ahead. Thank you, Bill, for the kind introduction. So thank you all for coming. So I am going to add to what Bill just mentioned. I finished the nephrology fellowship at this point, and I'm board certified. So I'm just going to be finishing up my informatics training by the end of this academic year. So just for me to understand a little my audience here, by a show of hands, who are the MDs here? Beautiful. Do we have nephrologists here in the room? Okay, hopefully they are watching the live stream. Okay. And then the rest are probably computer scientists, IT folks, predominant, I would think. So what I'm trying to do with this talk is try to give a little bit for everybody. So because of the nature of the topic, there are multiple aspects that are very important when we talk about EMR-based phenotyping. EMR stands for electronic medical records. So some elements will be quickly reviewed just for the sake of time to get to my actual research work. But then if any of you have any questions, we can get to it in more details later on. So like Bill said, I did my medical training in Damascus University in Syria when it used to be a functional country. I came to the United States in 2010, did my internal residency, medicine residency, and then clinical nephrology fellowship. And now I'm finishing up my clinical informatics training. So the outline is going to be the following elements. I'm going to briefly overview what EMR-based phenotyping is, just to make sure that we're all speaking the same language and have the same understanding at least. To a good degree, and then I'm going to go over a case study to highlight some of the clinically relevant aspect to EMR-based phenotypings. We're going to go over some challenges, and then I'm going to go over in much more details and focus on the national End Stage Kidney Disease program, and then the research work that I did in that domain. So a quick slide just to briefly review some of the terms that I will be using over and over. I found that this is helpful in my previous talks, so I kept it on. ESRD is end-stage kidney disease. That's when somebody has kidney disease to the point where they need dialysis therapy, which is the use of some machine to do cleaning of the blood to maintain life. The USRDS is the United States Renal Disease System. That is sort of the hybrid of informatics and nephrology. They are the body that collects data, analyzes data, and publish reports about the performance of dialysis units. CMS, that goes without explaining. Standardized mortality ratio, I'll get to it in more details, but that's basically a standardized metrics of the mortality of a dialysis unit. most of you are probably familiar with most of the stuff on the right side of the slide, structured data that we can immediately, or with minimal pre-processing, can be inputted in analytical processes. Machine learning is where we use predictive models without specifying predictors. The predictors are discovered by the machine. Natural language processing is where we use it mostly for text in the EMR-based phenotyping world, is where we take raw text and then create structured elements out of that we can use for downstream analytical purposes. Recall and precision, in the clinical world, those are sensitivity and positive predictive value. So what is EMR-based phenotyping? Well, the term phenotyping, it came from the phenotyping that is genomic and proteomics based, and that's the right side. If you look at a simple sequence of nucleotide, which is the TA, C, and G, that's what constitutes all of the human genome. Through multiple processes of translation and transcription, and that generates proteins. Proteins then fold and get together and then go to their destined target where they achieve a clinical effect that represents the state of the patient. That then gets captured in our EMR systems through big databases. The construct of those databases are zeros and ones, as we all know. So why do we need phenotyping? Well, we do know that we need better ways to identify cohorts for trials. We need to have a better sense of the cohort's multiple clinically relevant elements, such as their demographics, their comorbidities, and other things that are relevant for trials. Baseline characteristics is only one of them. You can refer to that as Table 1 in any clinical trial paper. Determining endpoints for clinical hypothesis testing, that's also one of the things where phenotyping is very important. One of the very common example is looking at CV outcomes when we do clinical trials. CV outcomes are a composite between strokes, MIs, heart failure, hospitalizations. All of these are endpoints that can be phenotyped from an informatics perspective. And then, as many of us know, the design and implementation of clinical decision support tools using phenotyping has had a lot of attention in recent years, particularly in the management of chronic medical diseases as an outpatient, but also has some role in the inpatient world. Along the same lines, there's also a role for phenotyping that goes into the management of the administrative processes of healthcare and other roles as well. But those are some of the key clinical highlights of the role of phenotyping. So phenotyping has two major ways, broadly defined, rule-based and computational. The rule-based one is where rules are generated based on a number of elements that you can then apply to a whole cohort, and you get your phenotype. So you can say, I will define diabetes as everybody who has hemoglobin A1C above 7. So that would be a rule. So a constellation of elements, such as vital signs, billing codes, laboratories, and medications are some of the common ones. Those are some of the common structured ones, but then you have natural language processing, which is a method to generate structured data that also can be used in rule-based approaches. The computational approach is a different one. It's where you're starting from the data itself, and then you're going up to generate your phenotypes and apply it on your cohort. You're not determining rules. You're using decision models to tell you which elements are significant predictors. So the method is different. If you look at a little bit in depth how rule-based phenotyping works, is basically you generate rules, typically by clinical experts. They sit together, they decide what defines something that they're interested in, and they are also responsible for curating databases, generating what a gold standard might look like. The knowledge engineers then take those clinical concepts, they map them to the data that exists in the EMR, which is not in a clinically relevant form. It's just data stored in a database. The process of the generation of the rules and then testing them, it's an iterative process where you keep working on your training data set until you reach a certain specificity and sensitivity, and then you apply it on a testing data set before you apply it on the whole cohort or other populations. The next generation phenotyping is used with also the term high throughput phenotyping, and those concepts are loosely used in the literature to determine, particularly high throughput, to determine for many people the capacity to execute rule-based or computational forms phenotyping on the data, on large data, and get the results quickly. However, the true high throughput phenotyping is probably better reserved for the ability to generate the phenotypes, hundreds or thousands of them in no time, in minimal time, and then the execution of large databases for the outcomes. So the actual generation of the phenotypes, when you minimize the role of the knowledge engineers, that's probably the best reserved for what true high throughput phenotyping is about. In the future, we'll probably see some more sophistication in the knowledge engineering, the top-down approach where you're starting by defining the rules that you want, and also the learning from the data. So a combination between a top-down knowledge engineering and learning from your data is probably going to be relevant in the future. Some of the well-known challenges that many of us know has to do with the stages before we even get to phenotype something out of the data. This has to do with the data standardization, the connection of the data, access to the data, having natural language processing platforms that are capable of being purpose-specific, not just generic, to achieve specific goals, and then the actual evolution of EMRs over time, because these things change. So those are well-recognized challenges. There are also the actual phenotyping challenges that has to do with the generation of features that are used. Features are the predictors, the rules that you want to use. This process is time-consuming. Few phenotypes can take months, if not years, to generate by large bodies that are working on this topic right now. Queries require maintenance. Clinical experts and the knowledge engineers both have biases. Once you get the human element into anything, you're introducing a set of biases that we should try to investigate. Features that are clinically relevant in automated computational learning is something that often goes missing because learning from the data is all treated the same without necessarily clinical weighting is something that needs to be kept in mind. And then the validation of those phenotypes, even though it's done, it's not a uniform process across the board, how to validate it where everybody agrees to the validation method. And then there are a variety of ways how experts annotate and chart review to define what gold standards and for those diseases are. So that's also not something that is uniform across the board. I'm going to transition now to a case study that I put together in order to highlight very important clinical aspects to the EMR-based phenotyping work. So this may be very clinically focused for many of you, and I apologize in advance, but this is really important for the clinicians that are here as they are trying to put their thoughts together with the informatician people, and also for the other part of the world to understand the clinical complexities of what we're trying to do here. So if we take a look at a 54-year-old male with chronic kidney disease stage 4, which is a fairly advanced chronic kidney disease that is due to long-term diabetes in this case. No other past medical history is reported. He takes lisinopril, glipizide, and furosemide. He presents to the ER complaining of coughing and shortness of breath and subjective fevers. The vital signs are remarkable for mild hypoxemia, and which is the oxygen level in the blood, and the heart rate is elevated to 120. The X-ray revealed bilateral airspace disease that can be interpreted as edema, which is fluid, pneumonia, an infection of the lung, and atelectasis, which is a collapse of a part of the lung. Some chemistries and blood work were within normal limits. The renal function was at baseline because it wasn't normal to begin with. Troponin, and a marker of the function of the heart, is slightly elevated, and so is the BNP, another marker. The patient was started on antibiotics. Ceftriaxone, azithromycin was given IV form of a what you can call a water pill to help the patient urinate. It's called furosemide. After a few hours, shortness of breath and coughing resolved and his fast heart rate and oxygenation also markedly improved. That cardiac marker troponin normalized, and then a subsequent evaluation with an echo on the heart showed that there was a normal structure and function of the chambers and valves. The patient was discharged with a prescription for an antibiotic, and a dose adjustment of his water pill was made to a higher dose. So let's look at the note here for those who are working on natural language processing. This note here, it may look something like this. You may have pneumonia, and then a description of the course of starting on antibiotics, and then for how long, and then the infectious workup that went with that. Description of the issue with the cardiac marker, cardiac injury marker, and the workup that was done in that regard. And then the decrease in the oxygen level in the blood, as we mentioned, the acute hypoxic failure was documented, and then the use of water pills. And then nephrologists were probably involved in the case to help because of the volume management in advanced chronic kidney disease often warrants nephrology consultation. So they helped with that. So this is what the note might look like for this patient. Let's look at the codes that we can retrieve on this patient after we're done, since we're trying to phenotype what this patient has. So you might get a combination of the following codes. I didn't put the exact numbers and the labels of the codes, just for simplification purposes, but it's probably going to be along the lines of these elements. Sepsis, inflammatory response, hypoxic respiratory failure, pneumonia, volume overload, heart failure, exacerbation, non-ST elevation, myocardial infarction, and pulmonary edema. So how do we phenotype this data? We presented the clinical elements, what a note looks like, then the codes. We can get into the medications, other structured data. How do we go about this? Well, if you're going to take a stab at this, it's probably going to look something like this. You're probably going to get a lot of signals for pneumonia. There are codes, there are medications. You can do some NLP and get that from the notes. And there are some other structured data that you can get as well. Heart failure, sepsis, volume overload, myocardial infarction. All of these have what many of us use as elements to phenotype and determine what this patient had. But in reality, what does this patient really have? Well, let's get into the case and see what was missing that we didn't do and go over the first time. The significance of no other past medical history was not taken into account when we did the original phenotyping, and I will get to this in a little bit as we talk about the probability that is pre-phenotyping. Subjective fever was used when the patient was evaluated and treated. A missing piece that we didn't use, perhaps we didn't know that we should have used, could have been used with natural language processing, is that there was mild pulmonary vascular congestion on the patient's X-ray. Other elements, there was the use of antibiotics. Another key element in this case is that after a few hours, the patient's symptomatology almost completely resolved, and the vital signs of abnormalities that he had also nearly normalized. We didn't mention what the patient did in terms of his urination, what he ate and what he drank and whatnot. So in this case, the urine output was 2.5 liters. For the nephrologist in the room, the ins and outs was negative for this patient. The admission weight, which we didn't use in the phenotyping, was up by 10 kilos. Putting aside issues with measuring the weight and its accuracy, let's say it's truly 10 kilos above the usual weight for this patient. And then we know that the patient was discharged with an oral antibiotics and an adjustment of his diuretic. So if we take another deeper look into what happened here, we see that there was a number of clinically implicit information that we did not utilize. So the relatively fast response here to the medical intervention is key. The short course of antibiotics for pneumonia is also key. It's unusual to treat pneumonia for 5 days, and it's unusual for pneumonia to have this fast of a response. These things favor certain clinical diagnoses that I will get to in a minute. And use clinical information. We talked about the urine output of the patient, his weight on admission. We may have used the documentation of leg edema as well, among other things that could have been used. and in this case, the noisy data that were introduced as part of structured and the unstructured data that has to do with sepsis and inflammatory response and the use of antibiotics. In this case, they were all noise. If we're going to take a deeper look, it's not going to look pretty black or white picture. It's going to be, from a clinical perspective, something along what you see here. You start off with the provider having multiple things on his or her mind with certain probability that he has in mind with the fact of advanced chronic kidney disease and no other past medical history and the diabetes. And after a set of diagnostics and therapeutics, that list and its probability and its likelihood gets adjusted after a few hours or the next day or two, perhaps even longer. But what you're going to see is that the suspicion for pneumonia is going to go down dramatically, because the patient nearly resolved after the patient's symptoms quickly improved after a few hours of medical intervention. Volume overload is something that was highly probable since the patient already has issues with his kidney disease. And then the presentation that has elements that are consistent with volume overload. Heart failure exacerbation, very unlikely in this case. The volume overload symptom certainly mimics it. It looks like it, but a normal echo almost nearly entirely rules that out. Again, the concept of 100% or 0% need to be left out, and we're thinking more of what is likely and not likely, what is least likely, and what is most likely. Myocardial infarction, less likely to be a main issue in this case, but the markers were a little bit up. The patient was at the right age and history of long-standing diabetes that it warranted further intervention. So what you see here is that the most likely phenotype that this patient should have was volume overload, most likely related to his chronic kidney disease, and all the other things were least likely or very improbable. Nonetheless, they were phenotyped with our usual methodologies of phenotyping. So with this, I will transition to what did we just talk about in this case? We talked about the recording process. Well, there are multiple processes here. We talked about the provider's part of things, his cognitive, his behavioral aspects, and the clinical logic by itself. All of these are part of the recording process. There are the whole host of health system processes that also needs to be accounted for, the EMR systems and their interactions with the other elements that eventually gives you the outcome of the recording process, all things that should be looked at. The clinically implicit information were relevant from the case, the missing data. Sometimes we think that the data is just missing, but that missingness can be used as a feature. It may be missing because it's not there, but sometimes it's not there because the provider did not deem it important enough to be there, either because it's not important or it's relatively very unimportant to other things that trump its importance. The unused data, same thing. We recognize that there were a number of unused data in the case that we presented. There's certainly the well-known difficulties in reaching the data that we need to reach, the technological aspect that needs to be developed, more custom natural language processing, all the IT side of things to get to the data that we need to use. But we also need to think that there's data that we should be using that maybe we just didn't think that they're usable. We should also mimic as much as possible the clinical process that ends up with what the phenotype, just like how the patient actually was diagnosed and treated, incorporating the concept of certainties as opposed to just binary. Does the patient have this or doesn't have this? So that's also something very important. Pre-phenotyping probability assessment, this is like a Bayesian approach imported from decision making. This is relevant to a lot of medical conditions that we work with, physicians work with. It's not applicable to every single disease, but it's applicable to a lot of diseases. So the probability of something coming in, even before you do phenotyping, is something that should be looked into, not only the elements that you're using for your phenotyping. So all of these are phenotypes highlighting the clinical depth that goes into phenotyping way beyond just the technological, the IT challenges that many of us already know. So I'm going to transition here. It's a big transition to talking a little bit about the End Stage Renal Disease program and my research in that domain. So Medicare covers U.S. citizens who are 65 years of age or older, or if they have End Stage Renal Disease, regardless of age, as long as they satisfied the work history requirement. It's a highly organized program. Frequent data are collected from outpatient units in all the country. The system has near complete inclusion of all people who have End Stage Renal Disease and are on dialysis. So that is a big cohort. The limitations that we know on the United States renal disease system that is well documented is that there's lack of continuous validation of methods, lack of complete comorbidity and other labs acquisition at the time of registration. There's some other inaccuracies that we'll get into. But there's a significant issues with the data. So why does End Stage Renal Disease matter? Well, let's take a look at the numbers here. The 5-year survival is 40%, meaning if you are on hemodialysis, 60% of people die within the first 5 years. That puts it somewhere between lung cancer and colon cancer. The cost, we have over 650,000 patients who are on dialysis. These patients represent less than 1% of the total Medicare beneficiaries, but the cost is close to 7% of the total Medicare budget. So a very small portion of Medicare beneficiaries taking a big portion of the budget. If you look at the trajectory of the cost, ESRD cost is about $31 billion. This is based on the most recent annual data report of 2015. They report up to 2013. There's a 2-year gap. So this is the most fresh data, and the cost is $31 billion. Well, if you look at the NIH all spending on research, that's $32 billion, and it's getting there. So getting into the background of my research work, the medical evidence report, also called as Form 2728, is the form where it gets filled to register people with Medicare in order to receive benefits. It's very similar to disability forms for people who are not nephrologists here. You need to report certain demographics, certain labs, certain comorbidities. I will show us the comorbidity section in a minute, and I will tell you how the data is reflected in the USRDS and the research that is done off of that data in a minute. One of the things that we already know is that 23% of albumin values, very simple structured data to report, is missing. There are uncertainties about the documentation of the cause of End Stage Renal Disease, the reason the patient ended up on dialysis as captured by that form. There are significant uncertainties that was documented by researchers. To take this to another level of depth, there were the agreement on the biopsy reports of kidney biopsies and what the documentation of what the biopsy findings for glomerulonephritis, a type of inflammation of the kidney. The agreement was only 23%. And we don't know how much of that 23% is due to chance, but it's very low, even if it's not due to chance. The agreement between claims data and the nephrology care that is documented on that form is 48%, with an agreement that is beyond the chance of 0.29, which is below agreement, fair at best. Agreement between the prescription record for erythropoietin use, which is a type of medicine to help with not having enough red blood cells in the body. The agreement was only 57% based on this VA study, and the kappa was 0.41. The agreement on nursing home use was a recall of 33% and a precision of 8%, which tells you that the sensitivity of the capturing itself is not enough. But when it's reported appropriately, then that tends to be more accurate. So the hypothesis of my research is that the reporting of comorbidities on the form, and I'll show you the form in a minute, using phenotyping algorithms is going to capture more comorbidities and potentially be more reflective of the patient's true disease state. The methods that we used, this was observational retrospective work. We defined the cohort as everybody who started chronic dialysis at outpatient dialysis facilities that belong to Indiana University Health between 2005 through 2014. The reason for choosing 2005 is that's the date they rolled out the most recent form to register patients for Medicare benefits for dialysis. So we started with that date. We excluded people who had the older version after 2005, and people who had unreadable elements were also excluded. The data sources that we used, we actually got the paper copies of all those registration forms. We got through the Indiana Network for Patient Care, which is part of the health exchange network that we have at Indiana, to get all the data from all the systems, not only the local ones on downtown Indianapolis, but all metropolitan Indianapolis. We got the data for up to 10 years, and I'll get to that in a minute. And we used CrownWeb, which is a platform that it has multiple purposes, but the data that we got out of it was the chronological history of End Stage Renal Disease. It tells you where each patient dialyzed for how long, and then if they transferred or got a kidney transplant, and maybe they failed and went back to dialysis down the road. So all of that chronological history was captured here because it's relevant for the calculation of mortality down the road. So this is the form that I targeted here, and there are about 23 comorbidities total here. The ones that are highlighted are the ones that I chose, mainly because we had the semi-functional rule-based phenotypes already existing that I was able to use, modify, adjust for my purpose, and then implement. As you can tell here, the requirement is to get as much as possible off of the last 10 years of that patient's life before the onset of end-stage renal disease diagnosis. The methods that we used some of the usual structured elements, billing codes, medications, and laboratory data, and for certain diagnoses, some other miscellaneous elements. We used natural language processing for inability to ambulate, and we used a proxy of wheelchair use for this purpose and created a Likert scale with the most likely that the patient was, in ambulating versus more likely versus least likely. We used some statistical testing for comparisons down the road, McNamara test for disagreement, t-test, and the standardized mortality ratio calculation was based on models that we got from the Kidney Epidemiology and Cost Center that is part of the University of Michigan that is contracted with CMS to do some of the analytical work. Go ahead.
Sorry to interrupt you, but just before I lost the thought, did you require that there were a certain number of encounters or longitudinal data about was there any requirement? And I don't think that you covered
10 years worth of, 10 years is the duration of all the data that the person filling the form for the comorbidity section. It's expected to be the nephrologist. It's expected to go back 10 years to get all the data that is needed to complete that section.
But I was thinking about your missingness piece, and you could have patients that have a lot of encounters, and that, like a lot of data, and then you could have patients where there is data that goes back 10 years, but it's very sparse, and it actually, especially related to the ambulatory piece, could be related. So I was just wondering if there was any restriction on that.
Well, Medicare does not care about that. They want you to fill it according to...
No, I meant in the way that you processed it.
Oh, the EMR data?
Yes.
So when they say you need to go back 10 years, they don't tell you need to go to as many EMRs as possible. They don't tell you you can only use your own system. They will tell you get everything that is needed to complete it. Does that answer the question?
No. So you're doing a comparison between two different data sets, two different sources of data, to see if they have a consistent result.
Correct.
One of which is the Medicare form, one of which is the EMR data. The EMR data could be just one encounter. It could be 100 encounters. How do you differentiate between the two?
I'll get to that question in a little bit. When we dissect why there was differences, I'll get to that in a little bit. The percentage agreement between the providers and the phenotypes are demonstrated in this table. The comorbidities are on the left. Anything that says computer positive means it was flagged by the phenotype as this condition is present. When it says negative, it means it's not present, or it's not flagged as positive. It might be simply unknown because of possible missing data. MD positive means that the box on this form here was checked. Negative may mean it's absent, but may mean it's unknown as well. So it's hard to tease out that possibility for the negative, for the unchecked box. So for example, if we look at here, this one, this 30% here for congestive heart failure, the computer said, phenotyping said that it's positive for 30% of people when the physician said that it's not present. And these are all the four possibilities for all the 2x2 possibilities. These are all the, for all these diagnoses, all of them were statistically there was significant difference between the two methodologies. So now we're going to get to answer some of those questions, which is, well, which data sources are we using? Which data sources the physicians are using? Are they using the same data sources? Well, with a health exchange network, you can use a big broad of data for as long as you want. So there's access questions about which data sources were used. There's the time question. Did the providers actually go back, even with their local EMRs, did they go back 10 years to document that minor stroke that happened 9 years prior for which the patient had no residual neurological function and documented in a different system perhaps, or just fell off, even if it's in the same system. So there's the time question. There's the scope of access, local versus more remote systems. And then there's a question which is, even if those two are the same, well, are the phenotypes just more capturing or just triggered so easily? Whereas the physician may have more specific logic to his way of interpreting the data that is not represented by the phenotypes. All possibilities, there might be more possibilities, but those are the ones that we try to address. So we narrowed down the source of the data to the local sources only. And we did this on multiple iterations. We started with 10 years, which is what is expected. But then to understand the differences, we came down to 8 years, 7 years, 5 years, 3 years, and down to 1 year. We also narrowed down all the EMRs from being everything that is metropolitan Indianapolis to only the EMRs that are in the local system, the downtown system, which the nephrologists are using for outpatient IU. So we tried different combination of these. I'm showing you only what you may call the worst case scenario, meaning just 1 year and only your local EMR. You'll see that many of these comorbidities are not statistically significant anymore, meaning that time and access explained why they were significant before, but some of them are still significant and still poses the question, why is there a difference? And what we get out of this is the next step. Well, does it matter? So when we looked at the comorbidity index and plugged it into the model that calculate at the end the expected death for that patient, and then plugged in the actual death for the patient and the group of dialysis patients, the actual death doesn't change. It's the same. We know this. The expected death was changed, and then the standardized mortality ratio was different between the two, and I'll show you that in a minute. The standardized mortality ratio, just a quick background, when it's 1.2, it means that your unit has 20% more deaths than the expected average. There are standardized mortality ratios that are nationals and by states, et cetera. But the concept is when it's above 1, that means your patients are dying more than the average, and when it's less than 1, your patients are surviving better than average. So it looks better if your SMR is below 1. There are other standardized metrics that we don't need to spend much time on right now that has to do with hospitalizations, transfusion ratios. Right now, the standardized metrics are not incorporated directly in any payment implications, but that may change very soon. The main payment adjustment is the quality incentive program payment, which take multiple quality measures that has to do with the patient's labs, their modification of calcium and phosphorus and PTH and blood pressure and other things. But right now, those standardized metrics are not incorporated in that payment readjustment model. So let's look at the standardized mortality ratio, whether using the phenotypes with the eventual expected death that comes out of that versus what is off of the paper copies of those registration forms that were filled by the providers. We looked at years 2009 through 2014. We started from 2009 because the Kidney Epidemiology and Cost Center did not have interactive models that we can use right away. It was just built in for their own internal use prior to 2009. I wasn't able to get a hold of anything that I can use with my research team. So we started from 2009, but what you can see is that for all these years, there was statistically significant difference between the standardized mortality ratio calculated differently by the two methods. And then the next question is, well, which one is the right one? Is it the phenotypes by the computer algorithms, the rule-based ones, or is it what the physicians reported on the form? So we formed a nephrologist panel out of 4 people. We determined an agreement is when 3 out of the 4, at least 3 out of the 4, agree on the output of those phenotypes. And we sampled all the cohort, and these are the comorbidities. So you will see that there was agreement between the panel and the phenotypes on many of these. It's exceptionally perfect for reasons that I don't fully understand on cancer, strokes, and substance abuse, maybe because these are the structured data that are used are just so unique. They're not, the noisiness in them is not as significant as for other comorbidities. But what stands out here is COPD and CHF, chronic obstructive pulmonary disease and congestive heart failure. The agreement was a coin toss, essentially, with what was reported on between the panel and the phenotyping. So the nephrologists were disagreeing 53% of the time with what the phenotype said. So the phenotype said it's positive. The nephrologist said, no, it's not positive. The COPD, 47% of the time where the phenotype said it's positive, the physician said, no, it's not. Then no, it's not was either a direct no or we need more data. So we combine these together in determining that what constitutes a disagreement. So what do we get out of this? Well, we saw that rule-based phenotypes were superior to manual form completion for many comorbidities, as judged by a gold standard of a nephrologist panel. We can talk about the nephrology panel itself as a gold standard, since we earlier mentioned that there's no gold standard for what constitutes the best gold standard anyway. But by judging by that panel, they decided that there was superiority to the rule-based phenotype as opposed to the manual completion by the providers. We saw that time going back as long as 10 years or going to a broader scope changes the outcome of the phenotype and gets closer to explain. So to explain what was reported on the forms. So when they were matched, when we narrowed it down, that suggests that the provider looked for close to 1 year using local sources when the phenotype is not different from what was reported. But it remained positive for many other comorbidities. We saw that the SMR was lowered, reflecting the higher expected death. And we saw that COPD and CHF, using the usual phenotyping elements, both had caveats that were significant and were not felt appropriate by the physicians, by the nephrologists. The plausible explanation that is to be tested is that both heart failure and COPD in non-dialysis population can be, as a diagnosis, can be reasonably made on clinical grounds. And we think that the fact that end-stage renal disease population are prone to recurrent episodes of volume overload, potentially mimicking the symptomatology of heart failure and COPD, that might explain why there were disagreement on this, and they were picked up so significantly by the phenotypes, which tells you that the phenotypes need further adjustment to cope with the end-stage renal disease population. Main limitation is sample size. We had 300 people only, and the generalizability is definitely an issue. The next step, so that was the first part. That is just testing out phenotyping and the physician's reporting. So we wanted to take that to another level. We wanted to see is that annotation, I'm going to use the word annotation from this point on to reflect that behavior with which the provider was deciding to check the box of each comorbidity or keep it unchecked. So if we set that annotation, irrespective of its true reflectiveness of the true state of the patient, as a target to do machine learning on, to see the consistency, is it predictable? We thought that if that is predictable, meaning if A1C, for example, is used consistently across the board to determine if diabetes is present, that will come up high in your machine learning approach because that's going to be consistent. It's going to be a high feature. Whereas, and I'm giving an example of a reflection of raise here. So if you have a smooth surface and all the data is coming in and being reflected consistently, systematically, the reflection will be in one direction. Whereas on the right side, with an uneven surface that reflects a more heterogeneous, inconsistent behavior, the rays will go in different directions when you're getting the same data. So we wanted to see what the predictability of that annotation is like. And so we did for my second research project, which we just submitted to AMIA, study of the predictability of the physician's annotations on those forms. So we got all the data, the labs, the medications, all the structured data from the IMPC. We put it in master data sets. We got all their labs and discretized those labs based on built-in filters with the software that we use that basically creates out of the continuous laboratory data that we have into categorical variables that are easier to use. We use different feature subsets. We use different decision models. We used an amplification method that's called SMOOT, part of in the different decision models that we used. And then we looked at the different metrics for the evaluation of those predictive models. Precision, like I said, is the positive predictive value. Recall is the sensitivity. The F measure is a composite of the two, and the ROC. So what does that show? This is what it shows. On the left column, you have each outcome. The best performing algorithm is the second one. MB is for naive Bayes. SL is simple logistic. The class is positive and negative. Positive means those are the ones that were checked on the form. Negative means that was unchecked. Precision, recall, and F measure, and the ROC. What I want you to look at out of this very heavy table here is the positive one, because there are a lot of issues with the negative one. What does it mean that the box was unchecked? Let's look at the positive for now and see what that means. We saw if you look at here, scan all of these quickly, you'll see, for example, for coronary artery disease, the precision was 0.7, the recall was 0.67, the F measure was 0.7. Generally speaking, and we consider good prediction when the F measure is above 0.8. But that's not the whole story. Some of these might be perceived to be reasonably predictive, but many of them are not. But let's take a deeper look into this. These graphs here, the top row is the precision, the second row is the recall. Each column is a comorbidity. So on the left column, coronary artery disease, precision and recall, cancer, precision and recall, COPD, and strokes. You'll see a few things here. You'll see that there is a very big difference in the performance of each decision model compared to the other decision models. You'll see that some of the decision models did not perform at all, like random forest in this example, as you can see here. This is 0%, this is 100%. So the best prediction is going to be close to 1.0. No prediction whatsoever is 0%. And these is the performances across the different feature subsets, meaning you're telling the decision model how many features to get from all the set of the data that we fed the machine learning algorithms. This is for the other four. We did this on 8 outcomes. This is heart failure, diabetes, peripheral vascular disease, and retinopathy. Again, not a great prediction. Very variable prediction. The the poor data predictors that we can get out of this for the provider annotation suggests that there might be a heterogeneous behavior to check that box or leave it unchecked. The provider annotations, we know from the previous study, may not necessarily reflect the true states, but certainly this data support that suggestion as well. And then we thought that the use of machine learning can be used as an effective tool to study the behavioral aspect for those, you can call them naturally occurring annotations. Usually we think of annotations in the world of phenotyping as, part of the research team. They're sitting together. They have data set they need to determine positive or negative. So you can test your phenotype algorithms on, or your machine learning. But what we're looking at here is that phenotyping that happened, that annotation that happened, that is not intervened on, that is not part of your research. You are predicting something that's already annotated. So that was a very useful piece of machine learning that can be used. And so the next step is, can we design a clinical decision support system with phenotyping ability? Based on this data that we just showed, there might be a very reasonable role for such a system. Can phenotyping predict mortality and other clinical outcomes? Certainly mortality is one of the big ones. We just talked about the ESRD mortality and cost. Issues with the data, clinical decision support with phenotyping may fit in just nicely for that sort of goal, research goal. Can we design a prospective trial, test it out on a bigger sample, bigger cohort, multiple centers? And ultimately, can that lead to well-designed predictive models where we can actually know what to intervene on, where we can reduce the actual mortality for ESRD patients? And I'll leave it to you. Thank you. Questions? Yes, sir.
Excellent talk, and every time I hear talks, you gave a very good talk, but every time I hear things like this, I get really depressed about what we're up against in informatics. But that said, so clearly part of the problem is this form, in that people who are completing it are, they're probably just checking off really quickly. In your kind of conversations with your expert panel, does it give you any ideas of how you might improve the data on the form so that the database that you're accessing could have more accurate data?
Yeah, so so first of all, when I off the record talk to some of the nephrologists, say, hey, are you really filling that section? Very few admitted that they just go off by what the other clerks in the unit gave them, which is usually the last couple discharge summaries and whatnot, to fill the form. Sometimes they actually go and check it for them, and they just sign at the bottom. So there's certainly some issues with is this fully reflective of the physician's annotation behavior or checking the box. But the concept of going back 10 years of data and being very able, actually I should backtrack a little bit. The nephrologist who fills the form is not the nephrologist who was involved, not necessarily the nephrologist that was involved in the pre-ESRD care. It might be in a unit that does not have the connectivity to all the EMR systems. It might be somebody who doesn't know anything about the patient and just gets the last couple discharge summaries. So there are certainly issues with that, not just if the physician actually dedicated the time. But what I'm proposing is that what is required to go up to 10 years and the possibility of so many EMR systems, even within one city, and the fact that physicians can go from multiple systems, those are very challenging aspects, even for the very motivated nephrologists. So we need to understand that what is required is very challenging to begin with, even for the motivated ones. So
I know there's probably others who want to ask questions, but just one quick follow-up. Do the forms ever get updated, or does the form just get completed once when maybe you develop renal failure?
That's an excellent question. No, they're not updated. They're used only once, only initially. So if the patient, 2 years down their ESRD course on dialysis, get diagnosed with metastatic lung cancer and die a few months afterwards. That is not captured, that is not reflected. The mortality is captured and will be part of the USRDS, data. I don't know what the degree with which they are able to get to that sort of data. I'm sure they're aware of such things. But right now, there's only that initial one that determines the comorbidity burden of the patient and does not get changed down the road. Excellent question. Yes, sir.
Very, very thought-provoking presentation, so really appreciate it. One thing I didn't get is, are you using natural language understanding of physicians' notes, discharge summaries, and histories and physicals, or was that not included in your model?
For the first part of the study, where we did the natural language processing, that was for inability to ambulate, because there was effectively no structured elements that can capture that as a condition. So that's why we use natural language processing. We use a proxy of using wheelchair with the likelihood of that to reflect inability to ambulate. For the second part, which is the machine learning approach, we didn't use natural language. We didn't use any structured element that were the result of natural language processing.
Because one of the things that it would be helpful to look at is the motivation for each of those structured data elements. So if you look at coding from a coder's perspective, those are notoriously inaccurate because the coders are coding for a reimbursement.
Right.
So anything that hints of congestive heart failure, they're going to put congestive heart failure, whether there's evidence for it or not.
Right.
On the other hand, for the discharge summary, the physician is interested in accuracy. And so that, I would submit, is probably going to be the most accurate.
I agree. It'll be more accurate for sure.
Right.
What I presented in the case was that even what is documented by the physician can be very noisy and inaccurate because of the timing of which notes you're capturing, and then there's a whole lot different layers of the physician, their hierarchy in the medical establishment. Are they interns at 1 a.m. Writing a note, or are they attending at 10 a.m. the next day? So those differences may play out a little bit, but certainly the challenge of the billing codes and their noise and inaccuracy is well recognized. Going a bit further to what I'm proposing is that even what is documented by the physicians can and should be questioned. Yes.
First of all, very good talk. Nicely
Thank you.
done. Thank you. But there's a lot of research that says that when providers are filling out the forms, they do it to support the plan they already have in mind. So, for example, if I wanted to give somebody Social Security benefits, I would try and rationalize that in the form I filled out. Given that, for example, drug addiction is a reason for disqualification from Social Security benefits, how would that affect the accuracy of this form relative to the EMR? Yeah,
that's a good question. Right now, my sense of this is that because there's not a whole lot of incentive to make this form as accurate as possible at the individual provider level, it's probably not playing out the role that you just described. But maybe down the road, if the implications on what's documented and reported is going to translate on the payments or whatnot. I mean, I'm sad to say this, but if it's going to be part of people's payments, then they will pay more attention to it and introduce some of the biases that you just described.
So you don't think there's a bias in the treatment that I want for the patient?
The determining of the comorbidities right now, the bias is more we just don't have time and energy to invest in it. But the bias that might happen down the road, if it's part of the payment, is to perhaps over-report things, which would be a whole different spectrum of asking the question. Here we're dealing more with under-reporting and some inaccuracies, but down the road, when it's part of the payment, there might be that possible bias. I mean, that just...
We're already seeing that with the Medicare review programs, where they're sending out doctors and nurse practitioners to review cases and try and upcode for the insurance companies.
Yes. It's not necessary yet, probably, to do that for this purpose. Not yet, anyway. Yes, sir.
This isn't really a question. This isn't really a question. It's more a comment on the last question. Just so we get it recorded. Was that okay? Maybe I don't want that. But it's interesting that where you saw, if I'm interpreting correctly, the best concordance was some of the things that, as a nephrologist, might be front and center. For example, recalling that a patient had cancer, which would make them ineligible for a transplant, or recalling that someone was a drug user, since that has implications for transplant as well.
Mm-hmm.
So,
yeah, that's a very good point. Sometimes we have to ask ourselves those questions when we're trying to determine the patient's getting a kidney transplant. And I can easily see how that can evolve in an actual ethical, did this person smoke their last cigarette, or their last drink just 5 months prior, and they could really use being on a transplant list right now. So those are certainly some of the issues that we deal with.
Did I misread your data? I thought that where we had the high concordance was between the EMR and the reviewer. Okay, is that, for example, you look at the EMR saying there's drug addiction, and when the panel of nephrologists who independently reviewed it, not the person who filled out the form, they had a very high concordance. And that's something that's going to be pretty much cut and dried based upon what's in the EMR. Whereas, yes, I'm going to get a positive UDS or I'm going to negative UDS.
Mm-hmm.
So therefore I can make that decision. The difference comes in, like, for example, smoking. The way we interpret smoking data in the EMR is horrible. Our stats on that are terrible.
The concordance part was indeed for the computer algorithms, phenotypes with what the physician panel, but if I understood you correctly, you are referring to the biases based on your last question here, which was the over-reporting or the under-reporting. So when you're determining somebody's eligibility, you're asking yourself how rigidly those criteria for transplant are followed by the nephrologist, if I understood you correctly.
But did you find that there was a higher concordance then between the EMR and the form for cancer?
For cancer, yes.
Okay, and for drug addiction?
No, between the panel?
No, between your form.
No, if we go back to that, the statistical difference was for all of the cases when we used all metropolitan Indianapolis and 10 years worth of data. That was across the board. So there was certainly more capturing by the phenotypes, the EMR-based ones, compared to the forms.
So your treating nephrologist who filled out the form had a very poor concordance with the EMR.
Correct.
Your panel of reviewers had a very high
concordance with the
EMR phenotype.
Mm-hmm. So patients had cancer, and it wasn't reported on their forms that they did.
Right. So I would take one more question. Our data quality expert here.
I'm not actually going to ask a question about data quality. I was very interested in some of your early slides where you talked about different degrees of certainty and the idea of weighing evidence. So moving away potentially from just a binary decision of yes, there's this diagnosis, or no, there is not this diagnosis. And I was wondering if that's something that you're planning on looking at more going forward, incorporating into your work.
Yes. It's very challenging, though, because we're starting off by how do we even get the pre-phenotyping probabilities of things. And for certain diseases, there's some literature, but for the most part, there's no such thing. And that goes into, the art of practicing medicine. We go in with our, even before seeing the patients, we have an idea based on their age, their initial presentation about what differential diagnoses we need to be thinking of. Not so much necessarily in a purely probabilistic manner in the sense that, pneumonia is its likelihood is 20%, but at least in a rank order or a relative order, if you will, across all the diagnoses that are on your differential diagnosis, and then that get adjusted. So the concept of that relativity is something that can be worked on and should be done. I don't know that we will get to the point where we will be assigning actual pre-phenotyping probabilities, because that doesn't exist even for the practicing physician.
Good. Okay. Well, thank you very much.
Thank you.